Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. That is on a very important topic, that is lupus nephritis to CNS lupus, a systemic review thought through cases. And for this, we need someone who is expert. Without any further delay, I would like to welcome speaker for today's session. He is none other than Dr. Ved Chaturvedi sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, DM, senior consultant at Sri Ganga Ram Hospital, Vice President of Asia Pacific Rheumatology League, and APLAR. So without any further delay, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed.
Can I have the first slide? Yeah. So, my brief is to speak about, let me introduce myself. I'm working in this hospital, Gangaram Hospital, and I did my DM from one of the first batches of rheumatology. And I was in Army Hospital for many years. Next. I was in Army Hospital for 35 years. Now after retirement, I'm working in Gangaram Hospital, and I'm proud to say that I could do my DM in few early batches of rheumatology from SGPJ Lucknow. Next. Now, we are not concerned of definition, but biggest problem with the lupus is the biggest harm of lupus is by that photograph which shows the butterfly rash. So people always think probably SLE means a butterfly rash. But if you read this definition, a systemic disease, so it's not a skin disease, it's a systemic autoimmune disease. So the most important word in this, it's a systemic disease. And next important word is autoantibody. So it's a systemic disease, means anything can be involved from head to toe, whatever you want. You starting from loss of hairs to the eyes, nose, everything. And relapsing course. Sometime you're okay, another time you're not okay. So that is the, and the last is almost any organ system. So you can have involvement of kidney, bone marrow, skin, brain, everything can be involved. Next. More common in female, young females, generally this age group, and there can be a family history also. Next. I'm having problem in the, because I myself I can't change it, so that so basically pathophysiology, don't try to remember everything, just remember that key components of the immune complex deposition causes. So there is a loss of self tolerance and so antibody production. So body started producing antibodies against its own component, like against the cell, against the nucleus. And if the antibody is against the nucleus, it is called anti-nuclear antibody. If it is, and that causes complement activation, and some genetic and environmental factor are also present. Next. Now this delay affects my presentation. The basically it can involve kidney, it can involve skin, and it can involve the intestine. So this is how. Next. So now this is more relevant for this crowd, that we know about the skin very well. You must have seen a lupus photograph with butterfly rash. So skin you must remember. But the best thing to remember, as I say, you start from head. So if you start from the head, then there is hair loss. Then you move, eyes are involved. It can cause the optic neuritis. It can cause retinal vasculitis. It can involve mouth. So the mouth ulcer, mucosal ulcer. Then it can involve the skin. So you have a photosensitive rash. It can involve joints. So you have arthritis. You can have anemia. So you have a blood disorders, not only anemia, it can cause cytopenias, and of course the head, starting from top. So CNS involvement, any type of thing, it can happen. You can have peripheral or central involvement, whatever you can think of, because of the brain inflammation, and of course the kidney disease. So the kidneys are involved. So that is how you remember from head to top. It is much easier to remember that. You will remember hairs, brain, eyes, mouth, skin, joints, kidney. Next. So these are the how it is written there. So you start from head to toe. These are the organs involved. This has become more popular because it is a butterfly rash. But otherwise, it's not that every symptom is important. Sometimes you can have skin involvement. Sometimes you can have only kidney involvement. So patient will not come to you. Patient will go to a nephrologist. Sometimes patient have psychiatric symptom because of the upper story. So they will go to psychiatrist. Sometimes joint involvement is there. Then they will go to rheumatologist. If somebody has only skin involvement, they will keep running behind a dermatologist. So they are called as multi-system disorders. Next. So, as I said, they can have musculoskeletal involvement in different way. Don't try to mug it up about the name that it is Jacquard's, there's that. Just remember it, they can present as arthritis. There is no actual characteristic of arthritis except that it is non-erosive. Next. So they can have some deformities also, which are correctable deformities. So you will always feel probably it may look like a rheumatoid arthritis. Next. Skin involvement. Now skin also, uh, you can have any type of features in skin. Can you imagine? It can, somebody will call it psoriasis, somebody will say rash, somebody will say a dermatitis, somebody will say eczema. Any type of skin lesion can be present, but for this crowd, the classical presentation is a butterfly rash and photosensitivity and hair loss and some rash and Raynaud's phenomena also. Next. So basically, any type of skin lesion can be present, which can be acute, subacute, or chronic. Acute is, which we all know about this. Subacute is basically a subcutaneous cutaneous lupus, which is a red, raised, scaly, non-scarring. While chronic is a scarring alopecia or scarring purple rash with discoloration and scarring. So you just remember there are skin rashes which can be acute, subacute, or chronic. Next. So this is classical, which we all know. Next. So basically, there are many areas which can be involved. So this we know it very well with the sparing of the nasolabial fold, but other areas also can be involved. Especially these type of rashes can also be there, which looks like a dermatomyositis rash, but this areas can also be involved. Next. Raynaud's, they can present as Raynaud's. Raynaud's means blueness of the skin once you have in the cold temperature. Next. Of course. Now, this is important because people will keep running from a post to pillar that they have anemia, and somebody will notice they have cytopenias also, means your total count is also low. You have a platelet count is also low. So there are many causes, but lupus is one of them. So cytopenia and anemia, you must remember. And these patients have lymphadenopathy, splenomegaly. Basically, cytopenias are there because the cell count become less because either it's trapped in the spleen because of splenomegaly, or there are autoantibodies against these cells. So the cell count become less and the platelet count also become less. Next. Yeah, so this is very interesting because this is missed by even very strong, good clinicians. So patient will be just going to neurological OPD. Doctor, I have a headache. So somebody will write a treatment of headache. they will present as seizures, fits. So somebody will write epilepsy. They have never bothered to ask about other symptoms, that do you have any hair loss, you have a oral ulcers. So we always keep telling our neurophysician that if you have a patient of seizure, kindly think of lupus also. Mood disorders, they will keep going to psychiatrists. Cognitive disorders, most common manifestation of diffuse this thing, they can present as stroke, neuropathy. So they are all going to neurophysician. Aseptic meningitis, myopathy, myelopathy. Next. Next. Yeah. So kidney involvement. Now, this is why the kidney involvement is important, because the fatality, the mortality is because of the kidney involvement. So they can have about 50% of patients. So if you have 100 lupus patients, a huge number of patients have a kidney involvement. So even if somebody has a skin involvement, you must see for the proteinuria, you must see whether they have a lupus nephritis. And this is basically based from the kidney biopsies, class 1 to class 5. And 3 and 4 are proliferative. So that is, you must remember. And ultimately, it leads to kidney failure and stage renal disease. And most important investigations are simple. Urine protein can be done anywhere. Creatine can be done anywhere. Of course, you have to consult a nephrologist for a renal biopsy if it is needed. And it's an important cause of mortality. Next. So there are different classification from class 1 to, don't try to mug it up. Just remember that if there is a lot of proliferation, it's called diffuse proliferative glomerulonephritis. So you have glomeruli, the glomerulus, everybody knows. If they are diffusely proliferative, this is called diffuse proliferative, that's called class 4. And if it is little less, this is called focal proliferative. And if there is only mesengium is involved, so mesengial proliferative, and sometimes only membrane is involved, that membranous. But even if you just remember the kidney is involved in a different fashion, either a glomerulus or membrane or mesengium, then it is, and it can lead to even end stage renal disease. Next. Yes. So when I came to Gangaram Hospital, I just saw a patient it was just going for operation. And then my rheumatologist colleagues, for some reason, it was a patient of lupus. So they decided to consult rheumatologist. And it was diagnosed that she has a CT scan was done. And it was because of lupus, the involvement, there is an edema around the bowel. So this is a GI is involved, and they present as a abdominal pain. And unfortunately, abdominal pain goes to surgeon, and if they operate, then mortality is more. So abdominal pain or nausea, vomiting, they can present, and abnormal liver enzymes also they can present it. So you must remember, a lupus patient coming with the abdominal pain, it could be because of lupus. Next. What happened? Next. Next. So, as I said, every organ is involved. So, eye can also be involved. So, it can involve the sclera, it can involve the conjunctiva, dry eyes, and vasculitis in the retina, and optic neuritis. And fundoscopy will show some exudates we call cytoid bodies. Next. Uh, they can have thrombosis also. So it's very, very important. So they can present thrombosis where in the heart. It can cause the clotting in the heart, infarction, clotting in the brain, stroke, clotting in the liver, hepatic vein thrombosis called Budd-Chiari, and the deep vein thrombosis like in the leg. So, and sometimes this antibody, which is called as anti-phosphorylate antibody, is positive. And if this is positive, then there are hypercoagulable state, which is more prone for clots, both venous and arterial. So every patient of lupus, if they have DVT, and all these patients, or young patients, young lady, young patient coming with these symptoms, you must do a ANA or anticardiolipin antibodies or both. Next. Kidney, the pulmonary involvement is also there. Sometimes they can be admitted like this, and you will always feel maybe it is infection. It can be, yes, infection also, but it can be pulmonary hemorrhage also, or a late disease like interstitial fibrosis, or maybe a shrinkage lung syndrome or lung pneumonitis. Next. Cardiac, all three layers can be involved, like pericarditis, most frequent manifestation, but it can be muscle involvement myocarditis, or fibrous endocarditis, which called Libman sex endocarditis, very popular, and of course coronary artery disease or a aortic insufficiency. Next. uh, Especially, you must remember, special population like pregnancy, higher risk, they can have more preeclampsia. In pregnancy especially, they can present with thrombosis or miscarriages. That's why these anti-cardiolipin antibody, anti-phospholipid antibody should be done. And safe drug in pregnancy, hydroxychloroquine is safe. So if somebody is taking hydroxychloroquine, and he will ask whether I should continue, you continue. They're safe. Low dose steroid is also safe, and azathioprine is also safe. Next. Pregnancy has a different involvement. Has a If a SLE patient become pregnant, so the biggest issue they will ask is, when should I become pregnant? So when you should become, you try to conceive when the disease is not active. That is number one, and you must warn them that it can cause problems. So you must do the antibodies like antiphospholipid antibody, those three antibodies which is should be, and you should be in touch with a rheumatologist. Next. Diagnostic criteria, there are different criteria. Basically, the anti criteria, the ANA should be positive. If somebody asks me whether there can be ANA negative lupus, extreme rare, just forget it. It has to be ANA positive. If somebody is ANA positive, and of those features which we discussed, and those features are given some points, they are called a scoring system by EULAR, and that is how we diagnose SLE. Next. So basically, the laboratory investigation, ANA, as I said, ANA is most important. It should be positive, especially the gold standard is immunofluorescence. ELISA can also be done, immunofluorescence. Then anti-DS-DNA is absolutely specific, 100% only, but unfortunately not that sensitive. About 33% DS-DNA is positive. It means 70% can be negative also, but ANA should be 100%. And same as NTSM. So NTSM and anti-DS-DNA, they are highly specific antibody, and RNP also. Antiphospholipid antibody, they are present, they are procoagulant antibodies. Complement less, and CRP is generally normal. CBC, as I said, anemia. And of course, the urine examination is very, very important. Next. So these are the types of ANA. Whosoever has not seen ANA under microscope, it looks like this. If this is the pattern, the whole is its nucleus is involved, is called homogeneous, and this is a mixed variety. This is a peripheral variety. It's a centromere. It's a nucleolar. And we have worked in the lab, so we understand. But those who have not worked in the lab, just go to your lab and see under the microscope sometime that is how they look like. Next. Imaging, basically, whatever depends on which organ is involved. So you can do X-ray chest or echo or joint radiography. Next. Biopsy, of course, skin biopsy and renal biopsy is important. Next. Criteria are, as I said, ANA should be there. So ANA is an anti-criteria. Rest is other organs, like you have involvement of the blood system, like leukopenia, thrombocytopenia, renal involvement. We have already discussed. We have already discussed neurological involvement, arthritis. So all these things are there. Basically, all systems, and they have been given some points. So that is how it is. They are diagnosed. Next. They are not diagnostic criteria, their classification criteria. The diagnosis is done by clinician based on ANA and multi-system involvement. The treatment is very simple. Treatment is hydroxychloroquine and NSAIDs for the swelling, and low dose steroid and immunosuppressant. And if there's a severe involvement there, then even these drugs like cyclophosphamide and biologics are used, especially in the involvement of kidney and other organs, other vital organs. Next. Life-threatening SLE, you have to use a high dose of steroid and cytotoxic drug like cyclophosphamide and rituximab. Next. Basically, mild, moderate, severe. So same thing which we discussed. For a mild disease, you require hydroxychloroquine. For a moderate disease, you require some other drugs like more steroid. And for a severe drug, probably you require immunosuppressive. Next. And for a refractory disease, you require rituximab. Adverse effects of the medication is also there. So whatever medication you're using, you must know about this. The biggest problem of this medication is infection and immunosuppression. So you must learn how to detect infection and how to control infection while using these drugs. As in oncology, you treat, when you give chemotherapy, there are a lot of infection. Next. And preventive therapy, especially when you are using these drugs, you must control the hypertension, osteoporosis, vaccination, and hyperglycemia and obesity. Next. Prognosis, 10-year survival is 90% as on today. Earlier, all patients used to die, but now it's a good survival. And it's a relapsing course. Better outcomes with early diagnosis. Next. So some cases are there. I'll just read a little bit. If a young female with fever of unknown origin. So fever is another very, very important. PUO, you have investigated everything, everything is normal. Then ask few questions about the joint pain, ask about oral ulcers, see the protein in the urine, see for serositis like pleural effusion. Most likely diagnosis is SLE. What is the test you will do? ANA. If ANA is positive, probably it is lupus. Next. Another case, basically, if somebody is having lupus and you're given hydroxychloroquine, joint symptoms are not under control, what is the drug, preferred drug? Methotrexate. But if somebody is young lady who wants that should avoid pregnancy, then steroid is a better drug. Because methotrexate cannot be given in pregnancy. Third. Next. Neuropsychiatric manifestation, should not forget. This is our patient. I'll just show you. This is a young girl who came with the movement of abdominal muscles. So she was moving abdominal muscles. So I didn't know what it is. So next, see, this is a video. Next. Next. Yeah, this moves probably. Just see whether it moves. This is myoclonus. Now, she came like this. Now, can you imagine in a OPD, busy OPD, if somebody comes like this, how to diagnose? But since we knew, again show. Yeah. So basically movement of the abdomen. So we diagnose myoclonus because of the SLE involvement. So this is called central nervous system involvement, myoclonus due to SLE. She had SLE already, a young girl. Next. Next. Another, this we can leave, this patient, this. Next. Next. Yeah, so these are the important take home points, that basically it's a chronic disease, multi-system disease, mostly in young women. So if a young woman walks in my office and has many symptoms, and a different symptom, you are a physician, you are confused. What is this lady? She's having some pain here, some pain there, sometimes she cries. So upper story involvement, she is crying. She has a mouth ulcer, she can't eat. She has some conjunctival, so eye involvement, and hemoglobin is low. So multi-system involvement, some skin rash, may not be butterfly. And this is disease is probably a lupus, and you must order for a ANA, which is called anti-nuclear antibody. and also order for ENA. If anti-DS-DNA is positive, then you are very sure about lupus. Otherwise, also ANA, because anti-DS-DNA is positive only 30% patient. ANA positivity and these symptomatology you can diagnose. There are some criteria for classification, not for diagnosis. And management, the drug of choice is hydroxychloroquine, and some immunosuppressant depends on which severity you are dealing with, and needs a regular monitoring and of flares and organ damage. Next. So I have finished. I have few more cases, about 5 6 7 cases, but I don't want to discuss because our time is up. If somebody wants to ask any particular question, I can answer. Only thing, if I was an audience, I will ask two questions: how to diagnose lupus, because after all, fever can be because of tuberculosis, fever can be because of malignancy. So prolonged fever and other systems like head to toe, I'll see, starting from loss of hairs, butterfly rash, oral ulcers, arthritis or arthalgia, skin manifestation, not only the butterfly rash, other skin manifestation, pleural effusion, pericardial effusion, maybe abdominal involvement, and cytopenias. So you must look for that, and plus ANA positivity. ANA positive in a good titer, 180, more than 180. So this is, and you must do ENA, the multiple antibodies. So that is how the lupus is diagnosed. If only skin is involved, skin mucosa, hydroxychloroquine is a good drug. Just use the low dose steroid and this, that's all. But if the vital organs are involved, like brain, kidney, then you have to use either cyclophosphamide or rituximab or mycophenolate. So that is how these are managed. Differential diagnosis, all multi-system disorder. It can still be tuberculosis, it can still be cancer, it can still be HIV. HIV is very, very important differential diagnosis for lupus. It can present to many physicians. It can present to hematologists as anemia and cytopenia. It can present to eye specialists. It can go to dermatologist. It can go uh, uh, to the stroke people, neurophysician. So there are and different department they present. So all of us should know about lupus. Uh, that's all from my side. If any other question is there, then I'm ready to answer.
Thank you so much, sir, for taking out your important time and sharing this important knowledge to all the audience, sir. I hope it will be helpful on their practice too. Sir, we have received some questions from the participant. With all your permission, shall we take these questions?
Yeah, yeah, yeah.
Yeah, first question I can see from Dr. Subramaniam. He is asking what investigation help distinguish CNS lupus from neuropsychiatric side effect of immunosuppressive therapy, sir.
Very difficult, actually. If you really ask me, not a single marker is there. Anti-ribosomal P protein, the people say that you, if you do anti-ribosomal, so it's more specific. But is it diagnostic? No, it's not diagnostic. So you need a good clinician who diagnose it. Is a good psychiatrist also knows it's not a psychiatric problem. It is a. I still remember there was a. In fact, there was a slide. Since time was up, there was a daughter of a gynecologist who was brought to me when I was a young rheumatologist, and she was under treatment of a psychiatrist. That psychiatrist noticed that she had not only the psychiatric problem, she has some other features. So see that gynecologist, he came to me all the from Allahabad, and then I noticed she had alopecia. She was losing hairs. She had little tinge of the butterfly rash. She had anemia. She has cytopenias. So I said, look, she did not have. She's a lupus. It's not a psychiatric patient. Of course, the question was which specific antibody. Probably the marker is anti-ribosomal P protein. I can't hear. You are muted. You are muted. You are muted. Yeah, now.
Am I audible?
Now I'm
Sir,
audible.
your
Yeah,
volume, sir, increase the volume. Yes, sir.
yes.
Sir, another question is from Dr. S. Ravi Kumar. He is asking, how do you modify treatment in patient with dual renal and CNS involvement, sir?
Look, both are very vital organ. Whether if you are both can be. It's not that you have to use a different drug for the CNS lupus. Only thing when these drugs were not there, like we didn't have that time rituximab, we didn't have mycophenolate. What we were using was the high dose steroid for the CNS lupus. But if some kidneys involved and you're using only high dose steroid, you are using either the cyclophosphamide, it is good enough. Otherwise you can you can add a drug like, say, mycophenolate. So both drugs can be used and multiple combination can be used. But even steroid and cyclophosphamide, or steroid or mycophenolate, or steroid or rituximab is good enough, both for kidney and brain.
Thank you so much, sir, for answering this question. Dr. Subramaniam has listened very well presented. Thanks for this amazing presentation. I hope, sir,
Thank you.
that they have really enjoyed this session, sir. Sir, I can't see any further questions, sir. With all your permission, shall we conclude this session for today?
Absolutely, I think that is the. So I also enjoyed it because lupus is very important. I always feel still we miss lupus because of its multi-system nature. So the last message is, if somebody which you can't pick it up, what is happening? Because patient have a lot of multiple complaint, and even ANA is negative. Try to do a ANA from a very good lab and try to speak to pathologist that we expect that ANA should be positive. Then you will get a better management. Thank you so much. Thanks, Jahin.
Welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take care of yourself, sir. It was great
Thank
honor
you.
to have you.
Thank
Welcome,
you.
sir.